Hello, and welcome to the second module in the Program Management Systems and Effective HIV/STI Programs for MSM chapter of the MSM Implementation Toolkit, or MSMIT, a tool that offers practical guidance for implementing comprehensive HIV and STI programs for gay, bisexual, and other men who have sex with men. This training is brought to you by MSMGF, the Global Forum on Men Who Have Sex with Men and HIV. This module, titled Planning and Implementing Comprehensive Sexual Health Services for MSM Part 1, is the first of two parts. In both parts, we introduce the steps involved in planning and implementing comprehensive HIV and STI services for MSM. After completing this module, you should have an understanding of 1. Program implementation levels. 2. A basic overview of how programs and standards can be defined. 3. Steps to establish a data system for program design and routine management, with an overview of data types for collection. 4. Sample indicators for monitoring and evaluating programs. And 5. Planning a program evaluation utilizing 5 dimensions of health quality. With these goals in mind, let's begin. We will begin with a general rule that applies to everything that is covered in the MSMIT. Working with communities of gay, bisexual, and other men who have sex with men from the very beginning of any process is paramount to designing and running effective programs. Creating a scaled program with public health impact requires collaboration among partners at different levels, broadly listed here as central, intermediate, and local. Some examples of levels and possible partners are listed here. The elements of a scaled program are outlined here. You can see that there are 3 broad categories: program design, organization, and implementation. Here, specific activities are listed for each program element. In each case, the highest level agency or institution takes the lead in planning each element in collaboration with the agencies or organizations at the other levels. Gay, bisexual, and other men who have sex with men should be involved in planning at every step of the way. Although we are primarily focused on central level planning here, there are multiple roles and responsibilities for each level of the program in management, supervision, and monitoring. Many of the elements described for a scale program are relevant to a program of any size. We will now turn to each element on this list and take a more detailed look. This module will cover the first 2 stages, which are program design and organization, and the third stage, implementation, will be covered in Module 3. We will begin with the first element of a scale program, program design. The first step in program design is defining program standards. To do this, it is very important to clearly articulate and understand the program logic model, the specific interventions that will be implemented, and the expected standards of implementation. This gives clarity and allows for monitoring and evaluation once the program is running. One way to articulate the program design is to use a logic model. A logic model is a flowchart that follows intervention inputs to outputs to outcomes to program impact. Depicted here is one strand of a logic model. They can be used to track multiple program strands and capture complexity. More information about how to create logic models can be found online. In addition to defining the parameters of program flow from intervention inputs to impact, it is also necessary to articulate a list of program standards to adhere to during implementation. These can be divided into technical standards and management standards. Here are 2 lists of questions for each that can help an organization develop program standards. All of these standards should be adapted to meet the context-specific needs of the intervention. The second step in program design is to establish a data system for program management. A routine data collection system is critical for assessing program reach and fidelity to design, the degree to which a program functions the way it intends to. A good monitoring system aggregates and consolidates information from frontline workers so that dashboard indicators may be monitored by the various levels of managers. It also gives managers the ability to look at detailed reports from lower levels. Here is a list of characteristics of a well-defined management system. For example, in a well-defined system, central or national management should be able to see data from the level of states, provinces and districts, while state-province managers and implementing organizations should be able to see data reports from frontline workers. This allows managers to identify areas or implementing sites whose performance differs significantly from the others and that may need additional management attention to improve. There are 8 principal data sources needed to design, monitor and manage programs for MSM. These can be used to create indicators which form the foundation of a monitoring system. Indicators measure services, track service utilization, and assess the extent to which an enabling environment is in place for HIV and STI prevention. The 8 principal data sources are: 1. Special data collection exercises. 2. Program data collected outside routine direct contact with men who have sex with men. 3. Program data from routine direct contact with MSM. 4. Administrative data related to services including drugs, consumables, and referrals. 5. Qualitative assessments. 6. Quality monitoring. 7. Expenditure data. And 8. Other outside data. We will now look at each of these in detail. The first type of data relates to special data collection exercises. Even if pre-existing estimates of MSM population size are available, it is always preferable to conduct independent population size estimates based on primary data if one is unsure of the methods used for the previous estimates or if they are old. This ensures that data is truly local and up to date. The multiply method and capture-recapture method have been used extensively to estimate sizes of population at risk for HIV. 2 special data collection exercises include mapping and spot polling booth survey. As always, participation of communities of men who have sex with men in population size estimations is critical. Given the high levels of stigma faced by men who have sex with men, their multiple identities, and the varying visibility of different subpopulations, size estimates may significantly underestimate some populations. Estimates should therefore be updated periodically, and remapping may be done if social, political, or economic forces lead to significant changes in the population of men who have sex with men. Estimates will become more accurate as the program gains experience and the trust of communities. The second type of data is data outside of routine, direct contact with MSM. There are 3 subtypes of this kind of data. The first is information regarding infrastructure by intervention type of both services for MSM and services for the general population used by MSM. These can be collected by intervention type, such as behavior change, condom provision, HIV testing and counseling, antiretroviral therapy provision, sexual health services and support services for people who experience violence. The second is information regarding program personnel, which is important to monitor service provision and human resources over the predetermined geographic area. The third is data collected when MSM enroll in a program, which can be used to set a baseline for understanding individual and collective program needs. Keep in mind that monitoring of infrastructure of services should include not only the availability of services, but also whether they are respectful of men who have sex with men, in order to ensure that they have accessible, acceptable services covering the full range of needs. The third type of data is from routine contact with men who have sex with men, ideally collected at the point of contact, is key to monitoring coverage. In addition to data associated with routine outreach activities, some data is generated more regularly, such as data on incidents of violence or access to entitlements. Because these events are not routine and usually require additional documentation, they are more difficult to track. It is recommended that sites submit reports routinely, even if there are no events to report, in order to understand whether low numbers reflect reality or represent a failure to report the information. A challenge to data collection of the total number of MSM receiving and accessing services is the high degree of mobility in MSM populations. Some ways to address these challenges are listed here. In general, the expense associated with installing electronic data collection devices at all service points and establishing and maintaining a centralized database makes the use of scannable IDs unfeasible for most programs. The fourth type of data is administrative data related to services, including drugs, consumables, and number of referrals made can also be used. The importance of administrative data is to ensure a consistent, uninterrupted supply of drugs, consumables, and commodities, monitor consumption or distribution as a marker of coverage, for example, condoms distributed compared to the estimated gap, and corroborate clinic reporting, such as STI drugs and syndromes reported. The fifth type of data is data from regular qualitative assessments of population needs with community members. This is important for the initial planning of interventions and, when done regularly, can determine whether communications are understood by recipients, whether stigma and discrimination persist, and whether there are unaddressed needs that might be met by the program. They may also be used to further investigate and understand answers on quantitative surveys. The sixth type of data is quality monitoring data. The standard setting process outlined previously forms the foundation of quality monitoring, as services are assessed against specific standards, quality assurance. Taking action to solve any identified deficiencies, quality improvement, is an important step to maximize service quality. The seventh type of data is project expenditure data. This data is important to monitor the project's financial status and ensure that payments to implementing organizations are punctual, so the program can continue to run. In addition, if coded in a standardized manner across all of the implementing organizations, the data may enable the program to estimate the cost per beneficiary for each of the implementing organizations and to reveal any that may need additional management scrutiny. Finally, the eighth type of data is data from other sources outside the program, such as government surveillance, academic research, or surveys done by other institutions, and may be useful to inform progress or highlight necessary adjustments in the program. Take a moment to check your understanding. True or false? Data relating to events like violence occurring irregularly and often rarely in MSM lives should be collected regularly. The answer is true. Even if there are no events to report, it is important to collect this information in order to understand whether low numbers reflect reality or represent a failure to report information. Now that we have covered the 8 types of data used in data systems for program management, we will turn to the third and final step in program design, which is planning the program evaluation. An evaluation plan at both the national and state, provincial level should assess the program's fidelity to its original design, as well as to its intended impact. Community involvement in evaluation design is a must. The 5 dimensions of quality of health interventions as defined in the RE-AIM framework are useful to guide program evaluations. They are as follows. Reach is the proportion of the target population that participated in the intervention, which this tool refers to as coverage. Efficacy is the success rate if the program implemented as designed and is measured through the evaluation efforts described below. Adoption is the proportion of settings adopting the interventions. Implementation is the extent to which the intervention is implemented as intended, which this tool refers to as fidelity to design. And finally, maintenance is the extent to which a program is sustained over time, which this tool refers to as sustainability. Now we will turn to some key issues to consider when designing the evaluation. Clarity is required on what is being measured and for whom, and how much certainty is required in the inference that the program contributed to outcome and impact results. These levels of certainty have been defined as adequacy, plausibility, and probability. Adequacy evaluations examine how well the interventions met the program logic model and whether the expected change occurred. Plausibility evaluations collect data to increase the level of confidence that changes observed were due to the program, usually by choosing a control group. In the case of programs with men who have sex with men, this is likely to be a historical control group obtained with baseline data collection. Probability evaluations examine the degree to which the intervention was responsible for changes. These involve randomization and are not required for most program evaluations. Data triangulation is conducted with baseline and end-line surveys, although baselines are sometimes challenging to obtain when working with an MSM population in the beginning. It is therefore important to try and collect additional information on baseline condom and lubricant use, high-risk sexual behavior, and service access and use through enrollment questionnaires, or to use program monitoring data to triangulate with survey data. Surveys used for evaluation should also be used to validate the other program data where possible. And finally, dissemination plans should involve activities at all levels, from central to local levels, including to the men who have sex with men themselves. Dissemination creates ownership of the results to help improve programmed. Before moving on, please consider the questions presented in this self-check and assess your understanding of the information presented in this module. This brings us to the end of the second module in the Program Management Systems and Effective HIV/STI Programs for MSM chapter of the MSMIT. To review, in this program we have looked in depth at the processes that comprise program planning and implementation. We focused on the importance of data management systems to successful program implementation and specific ways to use data towards that end. In the next module, we will continue our exploration of program planning and implementation.